you so much, everyone. My name is Grace Masharia. I'm a speech and language therapist, and I work in Nairobi. I work with the cross-section of patients, that is from newborn babies all the way to the age of the oldest you can get. I think the most recent patient I had was 104 years old. Yeah. As a speech and language therapist, I don't know what, do you know who speech and language therapists are? If I may ask. So speech and language therapists are professionals who work with people with communication problems, communication disorders. And as the name says, we work with speech, language, as well as communication. But on top of doing all that, we also deal with people with feeding disorders. Yeah, because the same organs you use for talking are the same organs you use for speaking. So you may ask, why would I be working with a newborn baby? A newborn baby deals, we need to make sure that we evaluate, because that is their formative years. We need to assess and evaluate so that if there's any child who is at risk of later developing language or feeding problems, early intervention is key. That we can be able to assist them so that as they continue growing, they are getting their developmental milestones that will allow them to live independently and live to their fullest potential. I trained in University of Reading, and I came back in the country to the 2011. So I've been practicing since then, and mainly I work in hospitals. So as a result, I come across all these different challenges with people with different challenges. But today we are not here to talk about speech and language therapies for everyone. We are talking about people living with dementia. Now, what is dementia? Anybody who can tell me?
It's a memory loss.
It's a memory loss. So when you forget your keys, you have dementia.
Yeah? It's a degenerational condition
Yeah.
that affects so many factors like memory,
Yeah.
our day-to-day lives,
Yeah.
and communication, how we communicate with others is affected in such things.
That is very true. So when we're talking about people living with dementia, we are talking about, this is not normal aging. Not where you say that, siku hizi nimezeeka, I'm actually don't even remember where I kept my keys. Or you're looking for your glasses and they're actually up your face. So people, there are different types of dementia. And this is as a result of different. So the dementia actually defines a group of symptoms that affect memory, thinking, and social ability that are severe enough to affect your daily functioning. Okay, and there are different types of dementia. They could be as a result of Alzheimer's disease. Okay, it could be a vascular dementia, or it could be Lewy body dementia, and especially for people living with Parkinson, and frontotemporal dementia. Now, all this is affecting the brain and the way the brain processes information and how it starts degenerating, and it's a progressive condition. So it is not something that you would say that will get better with time. It actually deteriorates with time. So the reason why we should be having this conversation is so that when you actually realize that somebody is struggling with some they're behaving in a way that they were not behaving before, it is good that they're reviewed by a neurologist, so that at early identification and early diagnosis is done, so that you can start planning about getting the best ability with people, because like we say, if you don't use it, you lose it. So when you realize that somebody's memory is actually getting affected, that is not the time to say, this one just keeps on forgetting. That is the time actually to start making plans as to how to improve that memory. Yeah, because the more you improve it, the longer it will last. Okay, so at least preserve already what you have, other than making it go downhill suddenly. That at least progressively you can be able to enhance or maintain, so to speak, the memory. Yeah? And communication is one of the things that actually is affected by people who living with dementia, because like I said, they will be talking and then they lose their train of thought. Yeah, they could be um, uh, as they continue progressing, you realize that they don't only forget that what they were doing, they even forget where they were. And that's when people start getting lost. So when you notice that your loved one is actually, like for example, they went out and they can't remember where their way back home, that is the time we start taking precautions, so that at least they are not left. You get at least somebody to be by their side or somebody to live with them, so that they don't actually get lost. Because I've actually seen quite a number of pictures or posters of people saying so and so was last seen, and they actually don't know where they are, and they cannot explain themselves because of communication problems. So when we get to that point is when we start thinking ahead. Like for example, thinking in terms of always having something in their pocket that identify a phone number. Maybe somebody can call when so they had something that in their pocket, at least somebody who can be reached to, and they can be able to call and ask where they are, or at least somebody to alert them that this person needs help. And the card you can have, you can even put some information that in case you find this person, call this number. And because they may not be able to explain where they are, at least call this number so that at least you can get in touch with somebody who, because most of the time when people get lost, the first thing we do is take them to the police station. And you know our Kenyan police stations, they're not trained to deal with people with difficulties. I know I met a young man who got a traumatic brain injury, and he developed language problems, and he got into contact with the police. And because he could not express himself, the first conclusion the policeman thought is he's drunk. And so they put him in the cells. And he's trying to explain to them that that is not the case, but this actually comes as a result of when you get a traumatic brain injury. The brain is the one, like I said, the left side of your brain is where we process language. That is the side that processes your speech, your understanding, your written, and your spoken language. Okay, so reading also can be affected. Reading and writing can be affected. So, and it is actually a language problem, not a memory problem. So, I'm touching two things. Sorry, I digressed and I'm telling you something different. So this person had a traumatic brain injury, had language problems to be able to communicate, and the police could not be able to understand what he was saying, and he ended up being put in the cell. But because he was cognitively sound, he texted his brother who was working in UK, and he happened to have been a part of Interpol. So they're the ones who called the Kenyan police to ask, why is this man inside there? So actually 2 policemen ended up losing their job because of. So, but it is not their fault, I would say. So I think we need to put a lot of this information outside there so that people, if we can be able to, people can understand that sometimes when you have a challenge, it is not your fault. Yeah. Like for example, God forbid anybody of us gets a stroke and you get it on the left side of your brain, you have a language problem. People will conclude that you're insane, and you're not insane. Your brain is intact, your intelligence is intact. And the same with people living with Alzheimer's. As much as their cognitive may end up declining, they still are the same people we live with. They are still our loved ones. If it is your mom, it is still your dear mom. If it is your dad, it is still your dear dad. And that does not change. Bottom line, he still needs that dignity and care and help. So, sorry for digressing. Like I said, my first training is a teacher, so I talk a lot. So stop me if I talk too much. Okay. Yes. So communication is one of the things that is affected when you're having somebody dealing with living with Alzheimer's. How can we help in communication with people who have dementia? Okay, so the first thing is we need to learn to speak slowly, short sentences, and clearly. So we don't like talk the way I'm talking, give a lot of information, half of the information we end up getting lost. So if you're already aware that somebody is losing their memory and a train of thought, so reduce the environmental noise, because that can also be very distracting. So if you're having a conversation, minimize the amount of background noise that is there. Is the radio on? Put it off. Is the TV on? If you're having a conversation, you'd rather have the TV off, okay? So that at least they can be able to pay attention, because they'll be distracted by the noise. And then using simple language and short sentences. Not because we are trying to demean them, but we are trying to make sure that at least they get the message we are trying to give them. Yeah? Because if you use very long sentences and give a lot of information, half of what you're telling them, they may not understand. So if you really want them to be engaged with you, minimize the amount of information you give and give short sentences. And avoid using abstract and complex words. Abstract is something that is not what would I say? Something that is not tangible, okay? Something like maybe like using metaphors and similes, yeah? They may not be able to engage with complex language as time goes by. So it is good to give something that is more relatable and something that will make it easier for them to understand the concept, other than trying, because what actually happens is that when you start losing your memory, your long-term memory is intact. So most of the day-to-day activities will be related to something that happened long time ago, but not what has happened in the present. So short-term memory is the first one that is affected. So something may happen and they do not relate with that, and they will remember something that happens long time ago. So it is always good to at least always set the topic, so that at least you know what you're discussing about. And then when they digress, gently bring back the topic, so that at least they can be able to relate with you. Because if you don't do that, then they kind of feel they're also not being felt. They're not being understood. Yeah? And so as a result, they end up having behavior issues and become very difficult. And like they say, I think the way we grow is that we grow up as children, we end up growing old like the same children, like the same status. So in the same way you talk with a child, but I'm not saying that you look at your dad and say, this is a child now. But what I'm saying is minimize the amount of language you use. Because when you're talking to a young child, you're not going to use very big words and talk about past and tense and future. They will. Present is more relatable to them. But like I said, as an adult, you already have your experience and your knowledge. So they already have that, and they have their long-term memory, and it will keep on creeping into your conversation. So gently navigate that in a gentle way, and in a way that is relatable, and in a way that is not condescending. I'm using a big word now there. Not looking down on them, but in a way that they can see that you appreciate their input and their conversation, and you're engaging with them. If you're to use question, ask one question at a time, not a series of questions, so that you deal with one thing, finish with it, and then move to the next. Because if you, sometimes we take it for granted that the way we talk, we can actually code switch and multitask and do so many things. But when things start breaking down is when you realize that sometimes it takes a process to do certain things. So if one thing is failing, you need to navigate in the sense that you need to slow down, so that at least somebody can be able to see the sequence of the event or the sequence of what you're talking about. As a grown-up, and maybe you have a wealth of information and a lot of knowledge you tend to, your brain is a computer and it can switch from one tablet to another. You can have a lot of tabs open and all that. But as you start getting Alzheimer's, then that does not work. You need to shut down some. You keep some and take one tab at a time. Yeah. So don't bring a lot of information, because when that happens, then they get lost in the conversation and they won't know where the beginning is and where the end is. Okay. Another strategy we can use is using visual aids and pictures and gestures. Just think of if you were to learn a new language, how would you learn easiest? Assume like today you woke up and you found yourself in China. They don't speak Kikuyu, they don't speak Swahili, they don't speak English, they're talking to you in Chinese. Do you think you'll hear what they tell you? You will, because you're not deaf. Hearing, you'll hear, but you'll not understand, isn't it? But for you to be able to understand, they have to go so low as to using a word and a gesture, and most probably explaining simple, like if you're teaching somebody your own language, you don't give them vocabulary, you just say, maji ni ya kunywa, unaweka maji kwa kikombe, and then you show them kikombe, and then you use gesture. And eventually, they'll hear those words and they don't make any sense to them. But the more you do that, the more it becomes easier. Now, if that is the way we develop language, now imagine you're losing language. So it is actually easier also to relate when you're using your gestures and you're using pictures. It is easier for them to relate to what you're talking about. And like I said, why would speech and language therapy come in? Early identification and early intervention, this is key so that we get this kind of information, because this is the time when we can start creating what you call communication books. Like we've already said that dementia is progressive. And we know early stages you'll be able to get along with everybody. Middle time you start getting lost a little bit. But by the end of it, you'll actually be lost completely. But how do we navigate those stages? If we start having like a picture book, think in terms of getting pictures of relatives, daughters, sons, grandsons, children, all of them, and you put them in a kind of like an album, okay? And then you put it in terms of maybe in terms of occasion. Like for example, a get-together you had at home, who attended during that get-together. And maybe, like December, most families get together. And this is when you meet your great-grandchildren and your all the siblings come home. And this one has, and the newest addition into the family, maybe young ones, having pictures and putting them there and putting their names and all that, how you did it. It becomes a very nice way to spend time with your loved ones. Memory, going down memory lanes. Looking at the pictures so that they can be able to relate and be able to keep those memories, associating the older memories with the recent memories. Like I said, you have the older children as well as even the younger ones, and even the newest any young ones that have been born into the family. So then they can be able to relate, and they can be able to relate that this is family of so and so, this is family of those and so, and this is how we relate. Okay? And that could be family. You could have friends. You could have specific activities that maybe they spend time with. Say, like, for example, if your mom was a choir master, or maybe spent a lot of time in the church, and maybe most of the time she had activities that she was leading groups. You could have memories of all the activities she have done. And then you could think in terms of your dad. Most probably he was the man who was mentoring all the young men, maybe in his business, line of work, yeah? Maybe he's the one who everybody calls to when you're looking for a career. Maybe he was a mentor. Then have all those activities that he was doing and relate about an occasion, maybe activities that he had spent time creating memories out of it. Like, for example, maybe even trips he had gone to, may it be family trips or may it be work trip related, so that even when you're having conversation at home, you have something to relate with, yeah? And keeps on those memories burning, because like we said, we don't want to lose it. We want to keep it fresh, and we want to keep it going the longest time possible. So those are the kind of things that, and then as you continue going like that, maybe as you now start seeing they're having problems in making choices, then you can have another picture or communication book that talks in terms of making choices. Like, for example, what kind of a meal would you like to have? Would you like to have ugali today, or would you like to have githeri today? Would you like to have your githeri with nyama, or would you like githeri with the sukuma wiki? Would you like to have your ugali with murenda or gwashi for breakfast? Yeah, so that you have pictures of those, because pictures, they say a picture paints 1,000 words. So those pictures, you can now actually use them for making choices. And you could also have Another one for making choices the kind of dressing she wants to wear. Because one of the things I've realized is that when people now start becoming dependent on us, we take away their power from them and we start making choices for them. And that can be very, very frustrating. Because remember, like we said, our loved ones are still our loved ones. They still remain who they are to us. But they still need to feel empowered, not disempowered. So when it comes to making choices like the kind of clothes they want to wear, don't just go to the wardrobe and decide this is what they want. And most probably she doesn't want to wear that, and you dress her and she throws a tantrum. You have a bad day and you don't understand why you're having a bad day. You're having a bad day because that was not her choice. But if you give her choices, can you imagine how empowered she'll feel that I was involved in making decisions? Yeah. So these are the kind of things that sometimes we don't think about, and we need to start having conversation about that so that we are able to assist our loved ones. Now, remember I also said that with dementia comes feeding challenges. Because as we continue having problems with memory, sometimes you may give your loved ones food and they forget that they eat. I know of a case where a family friend would be given food and then she'll say, leo hakuna chakula, and you have just eaten. Yeah. So this, yes. So that does not mean that she has not eaten, but this is the time now we also need to start thinking in terms of, do we get to a point where you give them food and they forget they were chewing and keep it in the mouth? Yeah. So that you need to have somebody who is kind enough, not rushing, somebody who is take time so that reminds them, yeah, we were eating, and in a way that makes them come back to what they were doing, and not in a way that it is going to traumatize them. Because I have seen patients who have force-fed and they end up stop feeding and they refuse to swallow. Why? Because the minute they get an experience of choking, remember your brain is usually the one in charge, and some of these things are reflex. So if your brain gets a choking experience, it will start thinking, oh, anything going through the mouth is a dangerous grape. So they don't want anything in the mouth. So if you force feed it does not matter whether it's a child or even an adult, they end up refusing, having disordered feeding. So they stop feeding now, wanting to feed. Now you have to start doing with your mouth like this, that is dangerous, feeding them with syringes. I always said never feed a patient with a syringe. Why would you do that? Why would I say that? Just think of it. If I had a pistol, I put 1,000 shillings and I give it to you, would you pick it? You'd think twice. You wouldn't pick it, eh? So why would you imagine that I would want to take food from a syringe? What is the first thing that comes to you when you see a syringe? Injection. So it's very traumatizing, yeah? So using utensils is the best thing to do. So you'd rather even adjust or adapt the feeding so that, and encourage your loved ones to feed themselves as much as they have the ability, as long as they have that ability. It's the safest way to feed, to begin with, because there's always that eye-hand coordination, because when you're ready, you have finished chewing, and then you can be able to put you in the, as much as even the memory is moving, we still have brain wired to some activities, so we still have that. They see a spoon, they'll open their mouth, isn't it? And if they're feeding themselves, they'll be able to coordinate. If it needs be hands-on support, let them hold the spoon, hold their hand, and let them feed. You're just assisting the movement, but they feel like they're feeding themselves. So you can feed safer for longer with support, other than taking that power from them, start force feeding them, then they develop other disordered behavior, and that is what is going to make them get at risk of feeding. So when should you start getting worried about your loved ones, especially in terms of feeding? In case you notice that they're actually losing weight and they're not taking food enough, so they're not getting enough, they've started losing weight, and you're not understanding why. I think that is the time you should talk to your doctor, your neurologist, so that they go for a review, and if need be, also to be reviewed by a speech therapist, so that we can find out, is it the weakness? Are we getting cases of choking? Can we be able to modify diet? Because most of the time we think that because this is an adult and has all the teeth, they should be able to eat as much as this. And sometimes you may just take it away and start blending, and it may not necessarily be appropriate, because if you're given blended food, it actually doesn't taste very nice. And you start actually even thinking, oh, now I've become a child. So there's a way of modifying diet that is safe to eat and not, and it is safe to eat, so that the whole idea is that we don't get anything in the lungs. Because if anything gets into the lungs, then we get what you call aspiration pneumonias. And aspiration pneumonias actually are killers, because if you're not breathing, then you're not able to live for long. And that, if it is bad aspiration pneumonia, it can take you to ICU, and they'll end up putting a tube through your throat. So that means we need to provide a quiet environment when they're feeding, so that they're not distracted. Use familiar utensils, so that at least they can know that what they have a cup is a real cup. Don't give them plastic if they're not been eating blood using plastic. Dignify them. Give them what is safe. Yeah. But if you notice that maybe the cup a little bit heavier, then modify the weight so that it is not that, but it should be something dignified. And then some small frequent meals throughout the day, other than expecting them to eat a huge meal. Yeah. You'd rather let them eat little by little and more frequently. That means you'll be able to take your nutrition in good time, and also you can be able to hydrate in good time, other than expecting they see, oh, this is daunting and they may not want to finish. And once they don't want to eat, then we don't want to force feed. Okay. Then easy to eat, such as soft food and fruits and vegetables. And then monitor for signs of choking, and if there's anything that is. And if you see somebody may not necessarily be coughing, but they're starting to have wet chest and fevers, then most likely there's something getting into the lung. Because sometimes we get what you call silent aspiration. You get a sensation of choking, that's when you cough. Yeah? But sometimes your senses also can go down and you don't feel it. So it will still go to your lungs, but you won't cough, but you still get pneumonia. So you'll end up getting fevers, and you'll end up getting wet chest, feeling hana homa lakini anakohoa, productive cough. So when you start seeing those are signs that maybe something is going wrong. Yeah. But like I said, dementia is progressive. You get to a point where now it is not safe to eat anymore. I know, and I have discussed this with a lot of families, and most of the time they say tube feeding, my mother is not going to feed by a tube. Now I'm talking to you as a professional. Find it in your heart to think seriously about your loved one getting safe nutrition, safe hydration, and medication if they're in case of they need to take medication. If anything they eat through their mouth gets into their lungs, you'll actually shorten their life. So there are 4 options of feeding. The first option is using your mouth. If you can't eat your mouth, especially if you're very sick, the first thing the doctors will do when you get to hospital, they'll put a tube in your nose. It's called a nasogastric tube. That is a tube that goes through your nose, bypasses everything, goes straight to your stomach. That tube is a short-term solution for feeding. You should, within 2 weeks, you should have started feeding already safely. Yeah? And this is where speech therapists come to assist you, making sure that we start feeding again so that we remove the tube. But if it goes beyond 2 weeks, it starts creating other issues. Because remember, we have 2 gates, one here and another one here, and that tube is passing through those gates. For mothers who have ever had a urinary catheter, once it's removed, the minute you sneeze, a little urine gets out because the gate is loose. So it's the same way, this gate gets loose. So every time they cough or they want to go for a long call, food starts coming back. Now, the system around here, there are 2 tubes. One goes to the lungs, one goes to the stomach. You don't breathe and swallow at the same time. There's a small flap called an epiglottis that closes the way to the lungs so that you swallow, then you start breathing again. You stop breathing, you swallow, then you start breathing. That gate is always upright because you need to breathe. The only time it goes down is when you swallow. Now, remember, it's always upright. So if food is coming from top, you get message that we are coming, so it will close. But if food is coming from below, there is no report we are coming. So it will come whoops, to your lungs. And food coming from the stomach usually has acid. So the pneumonia is more severe because it's coming with acid. So that's why Doctors will tell you, we cannot keep this one too long. We may need to put that tube here. Believe you me, it is safe to have a PEG. It's called a PEG. It's a short for a very long word. Percutaneous endoscopic gastro something. So it's shortened as a PEG. Yeah, a PEG tube. So that PEG tube makes it easier for the carer because you're not going to force feed your loved ones. It makes it easier for the person to get nutrition, hydration, and give you medication safely. And they can live as long as God determines them to live. So it is not up to us to decide how soon they go. It is up to God. So if we can support them to live, and when they have no issues with their chest, they're not having chest pneumonias and a lot of frequent, so they'll be more alert even to communicate. They'll be more alert even to engage with everybody around you. And you'll be more, you'll have the presence of your loved one as long as God allows that to happen. So, I know it, yeah? Percutaneous endoscopic gastro. It's a PEG. PEG. Yeah. So, in conclusion, yeah. Three? Oh, I didn't finish the options. So the first option was through the mouth. The other option is through the NG tube. The other option is actually through your veins. Yeah. Usually this is given to very sick patients and is usually done in hospital and is usually short term and is usually very expensive. So it's actually more of a hospital solution than it's not a long-term process. So the long-term solution is actually getting a PEG, yeah, and that allows you to feed safely, get hydration, get nutrition. Remember, you also need water, and water is the hardest to handle. So you can give as much as water as they need because they need other organs also running. Many people are getting a lot of dialysis because of not getting enough water. So we need to hydrate. All of us doctors say you should have 8 glasses of water per day. That is equivalent to about 2 liters of water. Sip throughout the day. Try as much as you can as you age. Finish your water before 5 so that you get quality sleep. Because you don't want to keep on going to the toilet at night. So by 5, finish your waters so that you're still hydrated and you can start again in the morning. But don't drink late at night because you need your quality sleep. Because if you don't get your quality sleep, you'll be a very grumpy person. Nobody wants to stay around you. So sleep well. Yeah.
I think the box you need to mention is also a TPN. It's the one that you read as well. It's just given for you to stay alive, not for in mass or muscles.
Yeah. So that is calculated nutrition that is just to make you survive and to make sure that you're alive. Yeah. So it's not a long-term solution. And it is best when you take food. And this will allow you to take anything. All you have to do, put it in the blender and take it. Put it. Yeah. Okay? So in conclusion, dementia can have significant impact on communication and feeding. And understanding the challenges and appropriate strategies for the caregiver will help you to improve the quality of life for that person who you love so much. Any questions? Anything maybe I didn't touch you wanted me to mention?
Yeah. One of the questions is what do you call it? The one through the mouth forcing.
Force feeding.
Force feeding. Because and I'm happy. Generally, let me just say I'm very happy because I've learned a few things which I didn't know about. But force feeding, which is now given through the mouth. I'm trying to think what we would have done many years ago. As went through a process with my mother about it, and I know that was prescribed by the doctors in hospital. So we used it for quite a while. and actually we used it for a long time. But I heard about the others, but I found it, of course I found it convenient about the risks that you have told us about. I'm happy to hear about those. So I didn't see the risk that particular time because it was easier than it was actually the only alternative that particular time because you're not open her mouth.
Force feeding is not, you don't dignify a person because you traumatize a person. Assume she's not ready, literally not ready to swallow, and you put enough food in that mouth. What will happen? It will let the blooding in the lungs. And you'll also have challenges removing it from the mouth because if she's not opening her mouth, how sure she has swallowed what is in the mouth? Yeah? Yeah. You know, sometimes ignorance is no defense, but sometimes God also gives us grace that because you're ignorant, He protects us. A lot of things we do out of ignorance, God actually allows us to survive it. But when we know, then makes a difference now. Because you already know you cannot do that, and you already know you actually even traumatize yourself. Because if you know what is the possibility of that food getting into the lungs, and you put it there, like me as a person who does a lot of feeding, I never leave food I've given in your mouth, I have to make sure it's out. So one way or another, I have to figure out how to do it. But if you don't force feed, sometimes it's very difficult for the patient to actually get into that. But I'm not saying it's impossible. It is not impossible because usually comes as a resistance because of you're being made to do something you don't want. So you create a defense mechanism. And once that defense mechanism becomes into your head, it actually now becomes real. And it's very hard to undo because it's a way of protecting yourself. Think about it. Any trauma anybody has ever gone through, you have to figure out how to survive. So your brain has to help you learn how to survive. So if you don't experience that trauma, then it's very easy to live. But if you have trauma, it becomes very difficult. So this is why we are having this conversation that if you have a person who is actually, we know the trajectory of the disease, we try as much as possible to minimize trauma, as much as possible to give care with love, understanding, and a lot of just talking them to sweet talking them to doing certain things, because the minute we resort to force, what happens? Even when people go to the street, the minute you resort to force, it always goes the other way around.
All right. So it's more of the concern of the family than the patient. Normally, that is what happens. You find that as a family, like, what will people say when they come to see him and they see us feeding in the tube? What is happening? That is normally it. So that's why we do more of it's like a workshop. We tell the family, why are we doing this? We're not forcing you. So before it is done, it is a conversation that is hard. So you understand as a family and as a carer, why are we doing this? It's not because we believe this person cannot feed, but it's because we want to reduce the risk of losing this person to either aspiration pneumonia or any other conditions that are going to lead them to death. I hope that makes sense.
And frequent visit to hospital. A lot of frequent visit to hospital which are not necessary. And then the other thing is, this is a disclaimer. Just because I recommend a PEG does not mean that I like it myself. And I would not recommend it if it's not necessary. And on top of that does not mean that we cannot work towards using oral for enjoyment. Like I said, I had a client who is 104 years old. She was put a PEG. When she was in hospital, she needed a lot of oxygen, so she went home with the oxygen in her nose, and feeding was very difficult. But the son told me, I would love my mom to eat. I used to move from Nairobi to Nyeri once a week and go and feed that lady. The last 2 months of her life, she was taking porridge in the morning. She would take some blended fruit in the afternoon, at around tea time, and something else in the afternoon. Why? What she was taking orally was for her own quality of life. Because at 104 years, what other joy do you have apart from food? And if you take it away from her, that there's nothing else she can eat. So she were not feeding her for sustenance. She was not eating orally for sustenance, for her own enjoyment. So she had the peg to do her nutrition, hydration, and medication. But in the morning, as long as it was safe, we'd rather even give 3 spoons of porridge, where she enjoys, and it is safe. And we don't have to fight as whether you can finish this bowl. Are we together? So it is still doable. That you still, it does not mean that once you get a peg, that's the end of you eating. If it is safe, we can take for enjoyment. And then for nutrition and hydration, the rest, so that you're not stressed that my mom is not eating enough, my dad is not eating enough, or my grandmother is not eating enough, my grandfather is not eating enough. They are getting enjoyment and they are getting nutrition.
Thank you. Maybe the final one, the last one I ask, what about there is a tendency of, there are some who grow big because of overfeeding. The current situation we have now is my sister who is now, she has really put on a lot of weight, but I don't know, I'm suspecting she actually eats a lot. She is able to feed herself. So, but I'm wondering if it is the medicine she is taking or it is the food. Probably both, because she actually eats a lot. You have kind of to stop her, but the girl who stays with her cannot stop her, because she even asks, because she talks sometimes, why I have to eat, the food is mine, something like that. So how do you, she has put on like
Now, this
many
is where
kilos.
I would suggest that you work with a nutritionist. Yeah? Because when you're working with a nutritionist, the nutritionist can be able to help you count their calories and count how much they need to do. Do you know you can eat a lot and eat very little calories? Yeah. Like if you take a lot of vegetables, she loves vegetables, give her a lot of 3/4 of the plate, make it vegetables that are going to give her minimum calories. And then the rest, you actually can work around food in any way as long as you're working with a nutritionist. So, and we also have to think in terms of moving from the mentality that vegetables are only sukuma wikis. When we talk of vegetables, our culture, I think we think of vegetables as sukuma wikis and spinach. And terere, yeah, and cabbage. There is a lot. You have broccolis, we have cauliflowers, we have a lot. You go to City Park Market, the number of vegetables, some of them you don't even know. Even Chinese vegetables are here with us. Yeah. So there's a lot that this country has to offer, that we don't have to just give waru and marenge. So, and once it is done nicely, they will enjoy it.
So from what I'm hearing then from you is that it's important then to actually work not only with the doctor, but also with the speech therapist, because a lot of times, now when I listen and even when she's talking, I'm thinking about, for us who had our parents who are unwell many years ago, we did not know way forward. We did not understand a lot of things. But now I'm seeing from what you're saying, like when you're talking to the son of the 104-year-old lady, you're saying he wanted his mother to experience that, the eating and the enjoyment of the food. So I think a lot of times when we either go to hospital, we are just told this is what needs to be done. But I think sometimes we also don't ask questions because maybe we are also at a point where we are trying to figure us out and we are thinking, like she was saying, it's a family. We are wondering, and then what next? And then isn't that more work for us? So I'm just hearing that there's more needed to have like a speech therapist on board with us as you're walking this journey with your loved one.
That is very true. And can I also say not just a speech therapist? We also have other people in the rehabilitation. You have physiotherapists and you have occupational therapists. Why? Because if you're not mobile, you don't use so much of the food you're eating. And that's why you're going to gain weight. Yeah? And also your joints will stop giving in. Then flexibility goes. Yeah? And if your flexibility goes and your mobility goes, then we're also going to compound your feeding issues. Why? Because you either are going to be sitting like this, yeah, or you'll be sitting like this, making it very difficult for you to put your head, because when the head is up, the airway is wide open. So you have to make sure that we have a neutral head position. So if somebody now start getting also contractures because they've been in bed for too long, yeah, then your hands start going like that and your body cannot move and we start getting bed sores and all that. But if you're working with physiotherapists, you're mobilizing that person so that at least not just doing passive exercises, but active exercises that they can get out of bed. They can make 1 or 2 steps around, or they can move around, and they can actually use activities like dusting. You know, we have a culture where once you get a house girl, you're umefika. Yeah? You don't want to do anything. But can you imagine even us before we get there? Yeah? Just taking your duster and washing your own car. You don't have to go to the gym. You'll have flex all your muscles, and your body will be able to get enough oxygen and blood running. So you need a physiotherapist, you need an occupational therapist. An occupational therapist helps you with activities of daily living, so that they can be able to maintain their fine motor skills, so that they can be able to dress themselves up, they can be able to feed themselves, and also the environment that is safe enough for them to navigate around without causing accidents. So it's not just a speech therapist, you need all the, and actually not the whole team, because also there's counseling, guidance and counseling to work with the family as well as the patient. Because remember, when you lose ability is a loss, and you have to go the whole through thing of grief until you get to acceptance. Because if you're in denial, your patient is going to fail, is not going to do well, and we have to be taken through that. So we have a lot of professionals that we actually don't think that they're necessary. And believe you me, you don't need a professional when you're sick. You need them before you get sick so that you get the knowledge. So once you get the knowledge, you prevent this eventuality. Yeah. So don't think that you come to a speech therapist because I'm having problems with me. Come to me, I give you knowledge so that at least you can move another 1-2 years without needing me to be active in you in care. Yeah. Just getting to provide that knowledge to assist the family to know how to navigate through some of the challenge and what to look for, so that you know that when we get here now, we need to go for a review, or maybe we check. Are we there yet, or is there anything that we have left out, or is something we don't need? And you'll be able to enjoy the whole journey. But if we don't do that, this is the kind of like, there was a WhatsApp group I'm involved in, where there was a video trading, where this gentleman goes to visit his mom, and the mother does not recognize him. And you get so traumatized. Why? Because remember, from the time you think your mother now cannot recognize you, you've been away for that long. So who bridges that gap? Do you call your parents? Do you call your grandparents? Do you visit them? Because if you don't get shocked when they can't remember you. And this is what you're talking about. Are we creating memories with them? Because if you're not creating with memory, then don't cry that they can't remember you, because you're not active in their care. So we need to think family is key. As many times, call your mom, visit them, see them. Don't get yourself shocked when you realize, oh my goodness, what happened? What happened to my mom? Because who bridges that gap?
I think a point to also note is,
A point to note is, as an organization that you've come together, there are those you've gone the journey before them. It's important, and this is a really great venture that you've undertaken. It's important to make this an occurrence over and over again, so that we can break down. What Grace has given today was basics. We have to dive into the details of when we think of how can we start. You've gotten the diagnosis. It's in the early stages. We know very well that dementia it's not something we can say it will be cured after this duration of this medication. It's progressive. But in something that is progressive, there's management. How do we manage this so that the progression of this condition is not as fast as we've been seeing? How do we do that? So that is where we come in. When we come in the early stages as speech therapists, as occupational therapists, as physiotherapists, you will notice the progression of the condition is not as fast, because this person still it's a cognitive challenge, isn't it? We'll tell you, let them have, this person enjoyed board games, make this a daily occurrence. Let them still do their chess. Let them still do their Scrabble. Do that with them. Be more intentional about it. If they were doing an activity, if they were in accounts and they want to do something in Excel, give a skill that requires the same, you're touching the same skill, but reduced workload. So how do you still use what you have to manage the condition to reduce progression. So I think that is really important. It's very vital for the people who are getting, because it's something that we keep now getting. It's good that we have new interventions. It's in that we have new ways of managing it. But how can we reinforce people to come, the families, not staying with the information, okay, we got the diagnosis of Alzheimer's, of dementia, we've been told that nothing can be done. How can we manage? Sending out the word on management is key from the onset. So I think that should be the word going out over and over again. Yeah.
In fact, what you mentioned just now about doing those things. It's like you are quoting me, because just before I left the house, so I told my husband where I'm going and why I'm going there. I haven't told him about this group, although I've been here before. So then he asked one of those questions that you have talked about doing things now, not tomorrow, not wait until somebody gets sick. I told him exactly that. The question you have asked, we should be doing now, before we get sick. Yeah.
And those social interactions where you meet with people, you have conversations, you have games. You're not meeting for buying plots and whatever. It's just having interactions and enjoying maybe a game of chess or golf or whatever it is. Connect with humans. We are human beings. That is what we're made of. But if we take that away, because like in Nairobi, everybody wants to be in their apartment. They don't want to be visited. You don't want your grandchildren to come and visit you because they make too much noise. You're losing out. Yeah, create opportunities to meet. Go to Karura. Karura has a space where people can run and you meet and eat and have fun. By the end of the day, you sleep like a baby because you've taken all the oxygen from the trees. Beautiful environment. Yeah. Meeting up with people, yeah. So encourage even older ones also, even ourselves, meeting, getting to have social gatherings where we just enjoying ourselves, not because we have an agenda, it's just enjoying life. Because we need to maintain. We don't want to lose it. If you don't use it, you lose it. So if you don't use it, it will go. So thank you so much for having me. I have some papers. I would like you to give some feedback. If you...
Yes, there are some special supplements which can reduce the progress of the disease.
I would say I'm the wrong person to answer that question because I'm not a nutritionist. I deal with food, the texture, the safety of it getting into your stomach, not the quality of it. So the quality of it, how much nutrition it has, that's a good conversation to have with a dietitian. I would be misleading you because I already have my own way of my mother, my own knowledge of what works. And most probably it's old women's tale, but maybe not necessarily professional advice. But for professional advice, I would advise that you talk to a dietitian, yeah, a nutritionist, and we have them. We have them.
Okay, you said we should not force. Supposing the patient does not want to take. Okay, you said we should not force our patients. Okay, about medicine. Sometimes she doesn't want to take the medicine. Okay, she keeps the medicine in the mouth. She tells you she has swallowed the medicine and the medicine is still there. So when you're going to sleep is when you see some whitish coming from the mouth. So she has not swallowed the medicine. So what do you do about the medicine?
You become creative about giving medication. If it is difficult to take a whole tablet, yeah. Again, you also have to be. You also have to talk to your doctor because there's some medicine that should not be crushed. There's some medication that is long running. Eh? So you need to know if you're to crush any medication, is it safe to crush it? Yeah. So what usually when it becomes very difficult to give medication, you crush it into a powder. Use something thick, like yogurt. Yeah. But this is not good for taking Parkinson medication. Yogurt is not a very good, because it has a lot of protein, so it reduces the efficacy of Parkinson medication, especially if you have dementia as a result of Parkinson. Okay, so it doesn't. You don't have to use yogurt, but you're getting the consistency I'm talking about. Now the secret is, do not mix your medicine with the whole pack of yogurt, because if it is bitter, they will not take it, and you won't know how much they have not taken. So you don't know how much medication has been taken. So what you do, just pour the powder, scoop it with a spoon, or scoop yogurt and pour the powder on it, give it to them. Yeah. If they swallow that, give them the rest of the yogurt. The yogurt will clean the palate.
So you're not supposed to give the medicine with the food?
You can even give it with food, but don't mix with the food. The
yeah,
secret
small
is
amount.
do
That is
not,
what we
yeah,
do, a small
do
amount
not
of the
mix.
food.
Just put it there so that they take the first food, then the rest of the food will clean the palate. Because if you mix all the food with it, they will not finish the food, and you don't know how much medication they have taken.
I have to talk to the doctor first before.
Yeah. Before crushing your medication, yeah. But if it doesn't, if it can't be crushed, I think it can also be broken, like maybe into two. Yeah. So if you're giving food that is chewable, you also don't want to give it with something that they need to chew, because they will chew it. Yeah. So you need something that they just swallow. You know, like yogurt, you just swallow. And then once you take the first, then the rest cleans your palate. They won't remember that it was bitter. But if it is too bitter, then they won't swallow it. Yeah. If you give it to them with water, and then a little bit goes to the lungs, goes together with the thing. But something thick like yogurt, or even cold porridge, don't give them with hot porridge. Okay? Something that thick is very easy. Just scoop and swallow. Scoop and swallow.
What of fruits?
Juice.
Fruits.
Fruits.
Like pawpaw.
Make sure that it's crushed. You know, you blended it, and it's thick enough. Add a banana or an avocado. Make it that thick. Yeah. So the secret, if it is the tablet, you can actually, with the small tablet, you can take a spoon, put the tablet, with it all together. Yeah. But if you give it with water, they'll swallow the water and the tablet remains in the mouth. Yeah.
That is what you do.
Yeah. Don't give with water.
You can even use 2 cups.
Yes, you will finish all the water and you'll not swallow it. So the secret is, put the tablet in the yogurt, it will go together. Inaendaga one sweep. Even people who have problems with swallowing tablets, try that. Yogurt, tablet, swallow. It just goes one sweep. Any other question? Yeah.
When they start holding saliva, you just remind, like my mom, just remind that we just. For me, it's about saliva like retention. So what we do currently is just to keep constantly.
How often do you do oral care? Brushing her teeth and cleaning her mouth?
Oh, morning and evening.
Morning and evening.
Yes.
If you're not talking and you're not actively using your mouth becomes gunky very fast.
Oh.
Yeah. So frequent use of just making sure that the mouth is being cleaned, either by using a spatula and gauze, just making run through that the mouth is not accumulating a lot of. They'll be encouraged to swallow their own saliva, but if the saliva is not tasted, they will not swallow it.
Sorry,
Yeah.
if
the saliva is not clean, they will not swallow it. So if it is clean, and then maybe you're frequently giving her something to sip, she will not hold her saliva.
Okay.
But if she's not talking and she's not eating, then saliva becomes very dirty and thick. She will not swallow it. Even you won't swallow it.
Yeah, eating she's eating is just that she talks less.
Yeah.
So maybe
you need to keep sips of
Sipping,
sipping of things, so that at least the mouth is active and she swallows.
Active.
Yeah.
Okay, all right. I can approach that.
But a lot of people also who get chest infection is as a result of poor oral care. So people who, even when you get a peg, you have to make sure that mouth is clean often. Yeah. So, and once the mouth is clean, they will swallow saliva. If it is not clean, they'll keep it in the mouth. You can imagine when you wake up very early in the morning and you hadn't brushed your teeth the night before. You don't want to swallow that saliva. It's the same principle. Yeah.
So about the food you say we should never pause. We should not force. Because like my patients, sometimes she wants to eat, the other time she doesn't want to eat. So we
Give her
we give
options.
the food.
Yeah, give options. Sometimes maybe the food is not tasty. If you have some nice food, you'll be encouraged to eat it. So look for options other than force feeding. Because I'm not saying that you can, but you're creating your own grave. You're digging your own grave.
Yeah, because sometimes she just looks at the food that she eat. She's like that. But the other times she eats.
Yeah, and have conversations. I know it is not our culture to talk with people, but if you talk to somebody and explain to them, oh, this food is nice, and you're eating with them, other than making it special for them, it is your meal and we're having our own meal. Eating with the person, you encourage them also to eat. Yeah, so you're eating and you're eating with her and explaining and commenting about the food. Oh, this food today is so nice. Yeah.
You think I share for you what I do with my mom. Yeah. We tend to watch. I can share like we watch a lot of what we call food channels when you are eating. So now she's seeing the person.
Yeah.
So we have a favorite program that we watch with her when, especially we have different programs. So we'll switch mostly to food content programs. So when she'll comment, when she say, hey, I want what they are eating.
Yeah.
So just like you say, just to create even humor.
Yeah.
By the time you know even you're
Food is
done
done.
eating. Yeah.
Environment, create a
Yeah.
conducive environment
Yeah.
for feeding. Yeah.
What happens when I know you are aware that this problem is progressive. Continues. Sorry, this problem, dementia, progresses from level 1, 2, and then it goes on. And of course, a time comes when they cannot talk at all. What do we do when
Talk to them.
Yeah, talking I do. In fact, like yesterday I was with my sister, but now I know, having gone through my mom's problem, somehow I learned a lot. You know, like even you, by the end of the day, you have learned so much. Yeah. So you learn a lot. So now I knew she wanted to go to, in fact, usually I don't do my nails like this, but we went to the salon. She was so excited the whole afternoon, very excited and all that. And but when it comes, it gets to a time when they don't talk. Whatever you do, they simply don't talk.
But it's not for us to keep quiet. We still talk to them.
Talking.
Because they're hearing. They're hearing. They need, and remember, communication is not just verbal. Because they can also even tell from your facial expression, your body language, what you're telling them. Are you cross with them? Are you happy with them? Are you encouraging? Are you telling them the words of encouragement? Just that in itself, you have done your work because it gives them motivation to see another day. But if you don't, can you imagine if you're left in a place where you're all silent and nobody talks to you? All they do is come and feed you and go, turn you over, and they go. It's a very bad. You'll actually even give up. But just having conversation and just telling, it's like somebody in ICU. Don't ever assume that somebody, because they're in a coma, they're not hearing. Yeah. And what kind of energy are you giving them? When you go to meet somebody who is actually at their lowest, are you uplifting or are you pushing them down? You're present. By the time you leave, do they feel better than you found them? Yeah. That in itself, you know that you have done your part. Because we know this is something progressive. There's nothing we can do about it. But if we have done our part, even our own self will live knowing that we did the best we could. And having done, they say what you put out will be done to you. Double measure, pressed down and overflowing. So we need to figure out what do we put out there. Yeah.
Thank you. And I think now, as you said, you are not a nutritionist. I'm asking our leader, at least get us a nutritionist so that we are sure we are giving. Oh my goodness. Oh my goodness. Yeah. So you know.
It's very interesting. She's really referring to the nutritionist because we had nutritionists We even sent notes on the group.
I somehow I didn't get it.
But your niece was here.
Yeah, she told me she was. In fact, I'm sorry. I think anyway. I'm not. I hope I'm not going to that direction because I know she told me about a topic I knew. I actually knew that time, but I think I forgot.
It's not you forget it because of her. She asked us what is dementia. And somebody said, then she asked, if you forget your keys, do you have dementia? So you're fine.
You're fine.
At least you remember there was a conversation. That is very good.
Yeah.
I'll tell her to send me.
Excuse me, that I have a certain patient
Yeah.
who says that she forgets English and Kiswahili,
Yeah.
but she can only remember her mother tongue. So does dementia affect other languages such that you can only remember the mother tongue only?
It's very, very possible because your mother tongue is the first language you learn. So all the language build on your first language. Even like you find that people when they get stroke, the first language that actually comes back is your mother tongue. Yeah, the first language. Yeah. But as long as you have 3 languages, you're covered. You have a language, at least you can communicate. Imagine people who have only one language. In fact, they say people with more languages, even your brain works better because you have a lot of words to express yourself. Yeah. So it's not something to be very worried about as long as you can communicate. And remember what we said, communication is not just verb or spoken. Communication is many ways. Yeah. Yeah. Part of the reason why we are talking about creating those memories so that even when you cannot speak, you can use pictures to be able to make choices. All right, thank you so much for having me.
Thank you.
Yeah.